Welcome everybody to the PrecisCa Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a GU medical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. I'm glad to be here.
My name is Preecish Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
This is a 80-year-old female with newly diagnosed clinical T4N0M0, uncertain M-stage, high-grade urothelial bladder CA with extensive squamous differentiation, and this is muscle invasive, and we're going to talk about the recommended treatment course for this patient. So this woman presented with a urinary tract infection, vaginal pain, bleeding. We treated with antibiotics unsuccessfully and then admitted with shortness of breath and an abnormal UA. She has a history of myocarditis and pericarditis a long time ago, recovered with murmur, but otherwise no other medical history. She does have an ECOG performance status of 3. And this is all very recent. In March of this year, she had a CT scan when she was admitted for shortness of breath that was negative for pulmonary embolism, but showed left hydronephrosis, had a subsequent renal ultrasound, which redemonstrated the high hydronephrosis and a large soft tissue bladder mass, then got a CT scan of her abdomen and pelvis and had a roughly 6x5 soft tissue mass in her posterior bladder that was outside the bladder, invading the vaginal stump and extravesical tissue and encasing her left ureter, and obviously that was causing her severe hydro. She underwent a cystoscopy showing high-grade urothelial cancer with extensive squamous differentiation, muscle invasion, and then on bimanual exam, a firm mass in the anterior vaginal wall. She had a percutaneous nephrostomy that had been placed, obviously, for her hydronephrosis. She's not a cisplatin candidate for multiple factors, probably renal function, age, and her performance status. And so the consideration is around some initial chemotherapy and then consideration of chemo RT as definitive therapy. Let me maybe stop there and ask Dr. Patel around, so I don't have a ton of experience with chemo RT and bladder cancer, but I'm not aware of data about chemotherapy first to downsize and then chemo RT. Tell me.
Yeah, I think in most cases, if we're proceeding with a bladder conservation approach, we in a situation where we're less worried about a very high risk of distant metastatic disease, so a very high nodal burden or something like that, you might then consider induction. But most of the time, we would really sort of start with the combination of radiation and concurrent chemotherapy.
Does my understanding is hydronephrosis would be a relative contraindication for chemo RT. Is that correct?
If surgery is on the table, then absolutely. If you're thinking about the option of, are you going to be able to safely preserve somebody's bladder? Those who have hydronephrosis would be the candidates you'd probably want to just proceed with the cystectomy. But a situation with an 80-year-old patient, ECOG 3, I think this brings up other issues in this case, and maybe there's not really another option. And I might add, it's a little tricky with these anterior vaginal cases where there's invasion and extensive squamous differentiation as to the true etiology of this disease. It says here that there's involvement of the vaginal stump, suggestive of a gynecologic surgery.
Mm-hmm.
And, we don't know the history there. And certainly we've had cases at our institution where it's unclear where the true primary was in this particular location. And of course, that could imply what types of treatment. Cisplatin would be the choice, of course, but in this case, I guess that's not possible.
Yeah, fair enough. Dr. Abel, do you want to take this patient to maybe a pelvic exoneration for surgery?
Yeah, I think if the patient didn't have such a poor performance status and comorbidities, I think that cystectomy might be the first thing to think about. And we definitely do a lot of cystectomies in patients that are 80, just because it does spare so much morbidity. Because as this progresses, it's going to be really hard to manage symptomatically. I think, and Dr. Patel probably alluded to it a little bit, as far as bladder sparing chemo RT, there's probably less data. Is this more of a palliative approach, or is this something that we actually are going to be able to cure in something that's clinically T4 bladder cancer?
Yeah, I think, given the stage at which this patient walked in the door, I think we're all thinking sort of just a palliative approach. I don't know that this patient has curative options given the extent of disease, inability to get cisplatin, and as you say, probably inability to get surgery. I don't know many surgeons who'd be excited about an ECOG 3 84-year-old. Let me ask Dr. Hussein about, he says not a cisplatin candidate and says due to multiple factors. What's the lowest GFR that you'll give cisplatin? Or maybe tell me more broadly the boundaries of in whom you'll give cisplatin: age, performance status, and renal function. The lower boundaries, what I'm asking.
I fully agree. I think I am selective in terms of the boundaries. I have actually given cisplatin to patients who are in great shape, great, functionality, no major issues except a creatinine that might be on the higher end of 40s or into the mostly above 50. So the guidelines talk about 60 and above generally. I've actually gone down to patients who are, I get patients that could be in their 40s, for example, and for whatever reason they have kidney function issues, but cardiovascular functionality, otherwise they are in great shape. So that would be that. Clearly, performance status is a major trump factor because obviously the side effect of treatment can be a big deal there. And I think age is not a discriminatory factor, but certainly is to be respected. In this case, when I saw this lady, she has just about on every front a reason not to give cisplatin. From a surgical perspective, she was not an optimal surgical candidate because of the nature of her tumor, and I'm not going to say it's fixed, but it's pretty extensive there. And the reason I put question mark Mets is because she had sort of like a high pelvic, lower abdomen, borderline lymph nodes. So to me, the critical part was really palliation in her case. And while yes, chemoradiotherapy is an option, and I wouldn't call, in her case, the intent is not really bladder preservation. In her case, is to try to control the cancer. After discussions and looking at the radiation port and everything else, and again, the personal experience, when you're talking about a major disease like this big, sometimes, again, from experience, you'd be better off downsizing it and then heading to chemoradiotherapy. And so there's more drama to the story, but that was the intent of the CarboGem. Now she's performance status 3, but sometimes, as you know, when you eyeball a patient is very much different than when you see the paper written. She's somebody that I thought I could get away with at least a couple of cycles of CarboGem to see if we can downsize and then go to radiation there. And this is a lady who actually was driving, working, everything 6 months before.
Wow.
Yeah.
So almost the approach like somebody who had advanced disease, right? Systemic therapy and then maybe local radiation.
Exactly.
Radiation.
Yeah. Radiation together, definitive radiation with radiation and chemotherapy. Chemosynthesizer with 5-FU.
So just to continue the story, so it was admitted for cardiac evaluation prior to systemic therapy, had atrial fibrillation, started on anticoagulation. And then now also has right hydro and needs a right heart nephrostomy tube place. So clearly an obstructive bladder mass. And then just kind of back to the question for the treatment course, which I think we've talked about. I'll summarize it. If anybody has anything to add, please do. I mean, this is, an unfortunate woman who walked in with advanced disease causing, local symptoms, local obstructive problems. And what Dr. Hussein was suggesting was approaching really as advanced disease with systemic therapy with maybe radiation added almost for just local palliation as opposed to a bladder preserving approach. Is that a fair summary, Dr. Hussein?
Well, it's more of a definitive treatment incorporating both local and systemic, therapy, basically, in her case. And unfortunately, what happened is then she started bleeding, and the bleeding was from the vagina, and end up having a TIA. And
jeez.
yeah. And so basically, we urgently started radiation for palliation, and the chemo right now is off the table.
Yeah. This is sort of an extreme example of some of the problems in advanced bladder cancer. This is,
Yes.
age and comorbidity, and you get this
Yes.
tackle one problem and then another happens, but this is sort of the ultimate example of it.